Well, welcome everyone to today's internal medicine grand rounds. And we are so fortunate to have with us today Dr. Pat O'Gara from Brigham and Women's Hospital. Pat is originally from Chicago, Illinois, had his undergraduate degree at Yale, then he got his MD at Northwestern, and then came back east and did his internal medicine residency and his cardiology fellowship at Mass General Hospital. Pat is currently the Watkins Family Distinguished Chair in Cardiology at Brigham and Women's Hospital, and he is a past president of our American College of Cardiology. And today he co-directs our ACC board review course. And so for cardiologists, that really spans interventional cardiology, coronary artery disease, electrophysiology, many different topics. He's been very involved in helping shape the face of medicine with his many gifts, but he has chaired writing committees, for example, the 2013 ACC-AHA guideline for the management of patients with ST elevation myocardial infarction. And he's also participated in several other guideline statements, particularly those involving valvular heart disease. He is a deputy editor for JAMA Cardiology, and he's also a senior investigator for NHLBI Cardiothoracic Surgery Trial Network. So what a great leader for all of us in cardiovascular medicine, and a very gifted, clairvoyant speaker. We feel so fortunate to have him today, and I'm most grateful to him for helping me in my career. Just been absolutely fantastic. Pat, thank you so much for taking time to come and speak with us today, and we greatly look forward to your presentation.
Well, thank you very much, Greg, for those very kind words. It's a pleasure and an honor, actually, for me to participate in your medical grand rounds. Dr. Syme, thank you as well, and I appreciate being able to interact with my colleagues from Richmond, Virginia. I always pause when trying to think of topics that could span the interface between medicine writ large and cardiology. We each are going our separate ways these days, but I like to remind myself from time to time that we're all grounded in the principles of internal medicine, whether it's regarding patient evaluation, treatment and prevention, or whether it's actually making sure that we understand the entire picture with which patients present and the multiple challenges that we have in managing them. I see that people are joining. I thought I would talk today about infective endocarditis, something that I'm sure that we share in large numbers, not so much from the perspective of all that we can do that is new, but I think as a nice example of the need for us to remain closely linked with each other in the multidisciplinary care of patients who present with this particular problem. These are my disclosures. I have no financial relationships with these two companies. I serve on executive committees for device trials. This is one of my favorite possessions. And tell a little bit of a story. This is actually an 1897 edition of the Osler textbook of medicine, which, as you can see, is signed in the upper left-hand portion of this slide by Dr. Paul Dudley White. Dr. White founded the cardiac unit at Massachusetts General Hospital around 1910 or so, after he had traveled to Europe to learn the new technique of electrocardiography. And as you know, Dr. White went on to have a highly distinguished career here in Boston. He became the physician-in-chief, of course, for President Eisenhower after his myocardial infarction during his first term while he was traveling in Colorado. And as you know, Dr. White was the first to declare publicly that it was likely safe for individuals following myocardial infarction to ambulate sooner rather than later. He was a great proponent of diet and exercise and wellness well before his time. I always like to think that I have some legacy with Dr. White, having trained in his program in the late 1970s and 1980s. This is a special textbook that sits on my shelf and oftentimes reminds me of the deficiencies that I continue to have as a clinician when compared against the likes of people like Sir William Osler and Dr. Paul Dudley White. Here's a quote from Dr. Osler's textbook. Back in those days, it was difficult to give a satisfactory clinical picture of the disease because the modes of onset are so varied and the symptoms are so diverse. And I think our trainees, that is our interns, residents, fellows, would possibly take issue with this nowadays because they see so many patients admitted to the hospital with acute bacterial endocarditis, oftentimes in the context of injection drug use. But back in Dr. Osler's day, there were other contributions to presentation. This is my favorite example of a patient for whom I've cared with infective endocarditis. Nowadays, of course, when I see a rash, I usually ask the patient, what's that? Back when I first met this patient, actually in the mid-1980s, she had come to the hospital and presented to the emergency room because she was concerned that she had lost track of her levothyroxine dosage for hypothyroidism. She hadn't really been aware of the fact that she had been losing weight gradually over a long period of time, had night sweats and fever. She thought, of course, that that could be related to hyperthyroidism. And then until we pulled the sheets back to examine her legs and feet, we were unaware of the fact that she had what you see here, namely purpura fulminans, in the setting of diffuse leukocytoclastic vasculitis, which is an immunologic complication of endocarditis. She actually had a streptococcal organism involving 2 cardiac valves, underwent successful surgery, left the hospital, and was not heard from thereafter. So well, let's talk a little bit about infective endocarditis in the 21st century. This is a problem, I think, that visits academic medical centers, especially those with surgical expertise and interventional cardiology expertise that exist at VCU. Well, back in Dr. Osler's day, of course, the valvular heart disease scene was dominated by rheumatic disease. Patients were generally younger. They had native valve disease, and they were oftentimes infected with streptococcal organisms of oropharyngeal source, less often with Enterococcus and with Staph aureus. And the presentation of the disease was indeed that of a subacute illness, and hence the term subacute bacterial endocarditis, or SBE. Patients showing up with weight loss, anemia, perhaps low-grade fever, lots of back pain, oftentimes splenomegaly, and then perhaps a cardiac murmur would be heard. But these are in the days prior to echocardiography and all the things that we now take for granted. Blood cultures were in their infancy during various stages, of course, of the 20th century. And a lot of this medicine was executed on the basis of clinical intuition, certainly until which time penicillin became available. I'm showing you an example here in the lower left-hand side of the slide of a patient with another unusual type of endocarditis, namely non-bacterial thrombotic endocarditis in the setting of a mucin-producing adenocarcinoma. This, of course, is really a systemic Trousseau syndrome that mandates the use of anticoagulation, which is otherwise contraindicated in the presence of a bacterial infection causing the endocarditis. Well, what do we deal with now? We deal generally with older patients who have a lot of degenerative disease and oftentimes have implanted heart valves or implanted cardiac devices, and oftentimes use injection drugs. It's estimated that approximately 10% of all the endocarditis now seen in the United States is seen in the context of injection drug use. That's a lot of endocarditis and a lot of injection drug use. Currently, of course, Staph aureus is king. It is the dominant pathogen when it comes to acute endocarditis in its various forms, either methicillin sensitive or methicillin resistant. And I think we've known now for decades about the pathogenesis of staphylococcal vascular infections, which sets up this kind of cascade that allows staphylococcal organisms entry into the subendothelial space, and then an amplification of the immune response system with macrophage and monocyte activity and the release of various cytokines and abscess formation with active pus and then of course denudation, degradation, and destruction of endothelial structures. And these occur, of course, on valve leaflets, but they also occur in blood vessels, typically at bifurcations, and hence the term mycotic aneurysm that occurs after infection with compromise of the integrity of the elastin fiber architecture of various sized arteries. Now, there's also something important, I think, for us to understand and appreciate with respect to endocarditis in the current era, and that is, unfortunately, an increasing percentage of persons without native valve disease now comprise the population that we see with endocarditis. Here is an example of a person, a patient of mine, who was healthy without valvular heart disease and developed strep bovis endocarditis on a normal native aortic valve. He unfortunately presented with stroke, had destruction of his aortic valve in the process, and required urgent surgery. Now, no talk is complete without some reference made to the intersection between injection drug use and the uptick in endocarditis, and certainly endocarditis warranting surgical intervention in the current era. I think you're all more than familiar with the opioid and crisis that has visited the United States in every nook and cranny over the course of the past 15 years or so. And I also think that you're quite familiar with the reality that drug overdose deaths have continued to increase over time, apparently without any end in sight. And this trend has been exacerbated by the COVID pandemic. Over here on the right, I'm showing you mortality rates, overdose mortality rates across the 50 states in the US. These are mortality rates per 100,000 residents. You can see Massachusetts up here in the top 10, and Virginia really in the bottom 50%. I suspect that these are as accurate as they can be. They come from the Department of Health and Human Services and the CDC. But this is an interesting set of statistics. I'm showing you some important data source from the Washington Post, but nevertheless, I think the message is pretty similar, and these come to us again through the CDC. If you can look here at overdose deaths in Cook County, Illinois, which includes Chicago, Illinois, you can see over the course of calendar year 2019, a gradual uptick in the number of overdose deaths. With the onset of the pandemic, there was a worsening or an increase in the number of overdose deaths in Cook County. And if you look across the United States, the OD map in particular, in 2019, there were approximately this number of overdose deaths per 100,000 population, and it has estimated to increase by nearly 40% in calendar year 2020 in temporal association with the onset of the pandemic. Whether people are not seeking care, whether depression has set in, or other things that contribute to the use of injection drugs has not been teased out. But certainly I'm sure that you have seen this in your own hospital-based practice at VCU. The diagnosis begins with a high index of suspicion, acquisition of blood cultures, and then of course imaging, beginning with echocardiography and then expanding to the use of other modalities that I will review briefly. And there's been multiple diagnostic algorithms suggested, beginning with a clinical evaluation. There is room for history and physical and the acquisition of blood cultures before the use of imaging. And then of course, endocarditis can either be suspected, verified, or rejected at that point. For clinical research in this regard, we still rely on the modified Duke criteria. I'm involved with a couple of projects, actually with our dental colleagues, regarding the use of antibiotic prophylaxis in the United States and the UK, and we rely very heavily on the modified Duke criteria by which patients are defined as having this particular disease. And as you can see, that once definite or possible endocarditis are ascertained at point of presentation, then further imaging is typically undertaken in order to define the consequences of the disease. When patients present with neurologic symptoms, for example, they have a CT scan. And for persons who have a prosthetic valve or have an implanted cardiac device like a defibrillator or a pacemaker, if the information from an echocardiogram is abnormal but ambiguous, then additional testing, typically with PET CT scanning, is performed in order to develop a definitive diagnosis in combination with the microbiology. So here's a typical person in the current era of injection drug use. Although this echocardiogram itself is 15 years old, I cared for this woman who was 26 years of age. And in the second trimester of her pregnancy, she had Staph aureus endocarditis affecting her aortic valve. This is a transesophageal echocardiogram with the left atrium here where my cursor is. This is the mitral valve over here on the left. This is the aorta to the right moving out. And this blood that comes back into the ventricle in diastole defines the presence of severe aortic regurgitation. So the combination of fever, severe aortic regurgitation, pulmonary edema, and low blood pressure in a 26-week pregnant mother certainly prompted a lot of consternation as to how best to proceed. Certainly, in this particular case, made the decision that we needed to save the mother's life as the first priority. She underwent cardiopulmonary bypass and open heart surgery and made it through the operation, made it through her pregnancy, and delivered a normal baby boy at term. This is another example of the use of transesophageal echocardiography in a patient with prosthetic valve endocarditis. Again, I'm showing you the region of the aortic valve here where my cursor is. Over to the right is the proximal root of the aorta or the ascending aorta. This is the left ventricle to the left. And here again, you can see the mitral valve with the left atrium. Now, what I'm demonstrating here is a pocket, namely an abscess in which there is unfortunately contiguity between the lumen of the aorta in the region of the valve and a pocket of infection that has eroded through the supporting structures of what we call the mitral aortic intervalvular fibrosa. This is the echocardiographic equivalent of an abscess in the region of a previously implanted prosthetic valve for which no medical therapy would ever be curative. This is an outright indication for urgent surgery. And here are some examples as well. This is a person with a bioprosthetic mitral valve, left atrium on the top. This is a still frame. Here's an arrow here showing a defect in one of the leaflets of the prosthesis, left ventricle here below. And through this defect travels, as you can see here, an eccentric jet of severe mitral regurgitation into the left atrium. Now, in this person, blood cultures had not yet returned. There was no evidence of vegetation, in particular on these mitral leaflets at the time of transesophageal echocardiography. So a PET CT scan was performed showing inflammation in the region of the mitral prosthesis. This is enhanced macrophage activity, of course, which drives the abnormalities that we see on PET scanning in the absence of metastatic cancer, confirming the diagnosis of prosthetic valve endocarditis. And a similar example here below, again, with a mitral valve that lights up on a PET scan. Here you can see the mitral annulus where my cursor is with the white arrow. And below as well, there's an abscess in the spleen. So multimodality imaging of this type can very rapidly and very astutely and very precisely identify the location of an infection and point the way towards intervention. In this particular instance, for example, the surgeons would need to pay some attention to the presence of a splenic abscess as a satellite source of infection for any new prosthesis that they would implant in the heart. There's actually prognostic value that can be derived in the context of a positive PET CT scan. I'm showing you information here in red on the top curve in this particular graph that implies a reasonable association between an abnormality seen on a PET CT scan and the incidence of a composite outcome here on the y-axis, which represents hospital death, heart failure, need for urgent surgery, or the recurrence of endocarditis following either completion of antibiotics or the performance of an operation. Now, I did say much about multidisciplinary team interactivity in our cardiology grand rounds earlier today, and I would just like to emphasize the obvious need for all of us to work together in the community approach to our patients with such complex disease as I've shown on the prior examples. I do think that internal medicine is really in the driver's seat here, and we'll share some of these experiences with you. Well, let's start, of course, in the ED, which is the place now where the majority of our patients present, and then are typically assessed for fever. Oftentimes, a murmur may not be detected in the ED. It's a little loud there. It's either the HVAC system or the continuous alarms or the continuous cries for help among the patients there. And certainly in the COVID era, we are examining patients less astutely than was the case previously, and point of care ultrasonography is not necessarily widely available or appropriately practiced. These patients then are typically admitted to the hospitalist medicine service, so things can be figured out. Complications are usually brought to the attention of the group of people I think are the best doctors in the hospital, namely infectious disease specialists, who have more powers of detective work than I think the average internal medicine specialist, certainly a cardiologist. Infectious disease experts help us understand issues around blood cultures, antibiotic sensitivity, the need for special nutrients by which to grow various nefarious organisms that can now populate the ranks of patients with infective endocarditis. And then, of course, cardiovascular medicine and surgery. Hopefully, the cardiologists are still included in the discussion as to the indications for early surgery. I can share with you, at least in my own hospital here in an urban environment in Boston, I'm actually sometimes the fourth of 4 people to be involved in a discussion about the indications for early surgery because people have wrapped up the discussion directly with a cardiac surgeon who has made either a decision to proceed or still, and somewhat unfortunately, a decision to, quote, sit tight and allow antibiotics to marinate for a longer period of time before getting the patient to the operating room. We need our multimodality imaging experts. That's why this has become the specialty it has. We need people like Greg Hundley and his counterparts in CT and interventional transesophageal echocardiography to help us find the gold, so to speak, when it comes to securing a diagnosis of endocarditis and then visualizing its early complications. Neurologists, of course, are important, especially when there are findings that affect the central nervous system. Neurologists are incredibly important when it comes to making decisions about the timing of surgery in patients who have had stroke, which, as you know, neurologic complications can occur in up to 40% of individuals at time of presentation. It simply depends on the assiduousness with which you look for the neurologic complication. Neurointerventionalists, of course, neurointerventional radiology can oftentimes help us plug aneurysms non-invasively, that is with coils, so as to make subsequent care of the patient safer, and also, I think, to preclude the possibility of rupture of a mycotic aneurysm. And then, of course, addiction medicine have come to the fore over the course of the last decade across multiple sites, and the insights that our addiction medicine colleagues provide with respect to the underpinnings, oftentimes of the substance abuse that has driven the unhealthy behavior that has led to the development of a systemic infection. And then sadly, the need on some occasions on an annual basis to seek the advice of the ethics committee when very difficult decisions need to be made about offering continued care to groups of people, some of whom may unfortunately relapse back into continued cycles of injection drug use to the extent that they present multiple times over a relatively short time span with new infections, not so much relapsing infections, but recurrent infections. And the number of times that you might be able to intervene successfully from a surgical perspective. And then, of course, the frustration that the workforce feels that we're only going to revisit the past by creating another pathway to the future. This is a very difficult discussion, and one size certainly does not fit all. So these are the indications that cardiologists carry, and I think infectious disease experts and cardiac surgeons carry, with regard to the need for urgent surgery during the acute phase of endocarditis, rather than treating for 6 weeks and considering how much valve destruction is left behind. What are the things that prompt you to want to operate on patients with endocarditis early in the natural history? Well, first and foremost is that the endocarditis has led to enough valve destruction that heart failure has intervened, or your ability with multimodality imaging to determine that there has been extravalvular extension of infection. Extravalvular extension could constitute an abscess, it could constitute a false aneurysm, it could also constitute a perforation or a fistula from one cardiac chamber to the next. And of course, if you've seen one case of endocarditis, you have seen one case of endocarditis. They all tend to act somewhat differently, and just when you thought you've been able to recognize a certain pattern, somebody will come in with a permutation on that pattern, like complete heart block or something of that nature. Now, surgery performed in the acute phase is associated with improved survival compared against persons who do not undergo surgery during the acute phase. These are old data. These data are probably 20 years old, and they actually came from 7 hospitals in Connecticut way back in the time before multi-center randomized controlled trials were up and running in great numbers. These are 7 hospitals in Connecticut that decided to get together and pool their outcomes in patients with endocarditis. And as you can see here, among all patients in this propensity analysis, which is one means by which to try to minimize the confounding that goes into so many observational studies of this nature. But suffice it to say, with propensity matching, there appears to be an association between the performance of surgery and improved survival over the course of 6 months in patients who have left-sided native endocarditis and severe mitral or aortic valve destruction. And this improvement or the treatment effect of surgery seems to be greatest for persons who have moderate to severe heart failure, complicating their presentation of endocarditis. Now, this particular association has been reported several times in completely non-randomized trials, most of which are retrospective and many of which are single-centered. Here are data from a European consortium showing a relationship between early surgery, or the percentage of patients who are operated on during the acute phase of endocarditis on the x-axis, and on the y-axis, in-hospital mortality. You can see this negative relationship that implies that increasing performance of early surgery before completion of a course of antibiotics is associated with a reduction in mortality. And these are outcome studies performed in single centers across Europe. And in the most recent survey of endocarditis in the current era from Europe, the so-called Euro-Endo survey, these investigators who have been looking at these kinds of data now for 2 or 3 decades, again, show this relationship with time on the x-axis and cumulative survival here on the y-axis. And for persons who have an indication for surgery, but do not undergo surgery, you can see that their survival in this observational data set is significantly worse than the survival of persons who have an indication for surgery and receive surgery, or against those who have no indication for surgery. In this particular registry, up to 30% of patients with an indication for surgery were not offered surgery. I can't tell you exactly why. Maybe they were thought to be too ill to be able to navigate the trauma of cardiac surgery. But it does raise a question, of course, as to how it is decision-making is made at time of presentation. Now, this field actually benefits from a publication of a randomized controlled trial. This is a study that was published, again, almost 10 years ago, a very small study of 78 individuals cared for at a consortium of cardiac surgical centers in South Korea, in Seoul, South Korea in particular. And this study looked at the performance of early surgery versus watchful waiting. That was the randomization strategy. And they looked at a composite outcome of death, heart failure, and systemic embolization or stroke over 6 weeks. And as you can see here in this relatively small patient cohort, relatively young cohort with a mean age of 47, left-sided valvular heart disease, that early surgery here in red resulted in a significant reduction in the probability of the composite endpoint driven exclusively by a reduction in stroke and systemic embolization. And this study has now served as a benchmark against which some of our decision-making is now met. So for patients who meet the entry criteria for this study, namely you have severe left-sided valvular disease in the context of endocarditis, oftentimes with large vegetations, oftentimes with a history of embolization, these patients a priori do better with early surgery rather than watchful waiting, antibiotics, and then operation for a complication. Now, tricuspid valve endocarditis in this particular context and in this particular era of injection drug use is perhaps the most difficult area for us with regard to decision making. Tricuspid valve endocarditis is very common among persons who inject drugs, and particularly with Staph aureus or a polymicrobial nature. And I'm showing you, again, this is a study looking at the tricuspid valve. This is the right atrium below, right ventricle here, and you see all of this sort of shaggy material hanging off the valve as it opens and closes, consistent with a huge burden of mobile vegetative mass that is likely to embolize and would be difficult to treat with antibiotics alone. And here on the right, the color jet that you can see confirms the diagnosis of severe tricuspid regurgitation. Now, decision-making in these patients is very, very difficult, but I'll just share with you some statistics. The incidence of tricuspid valve surgery reported to the STS database has increased from about 120 cases in 2011 to 625 cases in 2016. And this is the last year for which these data are available. This was just published this week in JTCVS. So you can see here that the prevalence, I should say, I'm not sure about the incidence because we don't have the denominator here, but the prevalence reported to the STS database increased by a factor of 5 over a 5-year period of time. And if you work at West Virginia University, where Dr. Badwar is the chair of cardiac surgery, you can see here this incredible uptick in the number of isolated tricuspid operations performed at West Virginia University over the course of the past couple of years. And 90% of these cases involve persons who inject drugs. West Virginia, as you know, leads the nation in overdose deaths related to opioids, as well as a few other substances. West Virginia University leads the nation in the use of cardiac surgery for the treatment of severe tricuspid regurgitation in the context of injection drug use. There are other indications by which we would consider surgery, and perhaps the most difficult of all is the presence of a vegetation alone, typically on the anterior leaflet of the mitral valve, that may or may not have already resulted in a stroke or some kind of systemic embolization. There are really no hard and fast rules in this particular regard. It's fair to say that the treatment paradigm has moved iteratively in the direction of surgery as the results of surgery continue to improve and our ability to make these diagnoses continue to improve. But nevertheless, this is an area in which we always struggle as consultants. And I like to point out that these ancient data from the international collaboration on endocarditis, which completely reduplicate what was reported from the Mayo Clinic 50 years ago, underscore the reality that if you start patients on appropriate antibiotics at time of diagnosis, their risk of stroke and embolization falls precipitously over the course of about 10 days. So if you're seeing patients at day 10 following presentation that have vegetations and have not had stroke, the incidence of stroke thereafter may be so low that the use of preemptive surgery in that particular context no longer makes sense. And we can't forget, of course, that the performance of surgery itself is associated with a small risk of stroke. But what do we do for our patients who do present with stroke? This is not uncommon. And many times we find stroke neurologic imaging for the performance performed in the context, for example, of confusion and maybe a headache, and sometimes without any specific symptom or sign, simply on the basis of a enhanced concern that embolization may have occurred, for example, in the context of Staph aureus or other organisms that are known to have a high predilection for embolization, the Hayseck organisms, for example. Here's a small stroke involving a portion of the left MCA territory in this person, and by current neurologic and neuroradiologic standards, this ischemic defect is not large enough and is not associated with enough hemorrhage at baseline to constitute a significant contraindication to moving to cardiac surgery, heparinization, and cardiopulmonary bypass. This is the finding at time of surgery. Here's an example of a person that I saw in the neurosurgical intensive care unit. This gentleman had presented with a psoas abscess, aspiration of which grew streptococcal organisms, following which he had a physical examination that revealed the presence of a heart murmur consistent with mitral regurgitation, and then had this transesophageal echocardiogram in which you can see a small mobile vegetation that's flipping mostly off the posterior leaflet, although the anterior leaflet of the mitral valve here is quite shaggy and most likely infected. But what you'll see is a relatively modest amount of mitral regurgitation into the left atrium. This gentleman had no heart failure, no change in oxygen saturation, no atrial fibrillation, and no signs of extravalvular extension of infection. And he was scheduled to undergo surgery for treatment of his endocarditis 48 hours before we were asked to see him to verify that that was the right decision making. We didn't think he had the tickets to undergo surgery from a cardiac perspective, and that there was a high likelihood he could be treated successfully with antibiotics. Well, this happened 2 days later. This is a ruptured mycotic aneurysm. CNS abnormalities had not been known or actually suspected in this gentleman, who had a normal mental status and had a normal neurologic examination and suffered this complication. And certainly, as you well know, rupture of mycotic aneurysm is associated with an 80% risk of either death or the establishment of a large fixed stroke. You see this white contrast or this white density here in the middle of his ventricular system. He did have a neurosurgical procedure in which they attempted to decompress one of the ventricles. And in the process of delivering this particular probe, they tracked the infection to the contralateral hemisphere inadvertently, of course. And the gentleman spent 6 weeks with kind of a diffuse cerebritis type syndrome. Nevertheless, he made a full recovery without heart failure and without cardiac surgery, and had normal mental status at time of discharge. I haven't talked to you about implanted cardiac devices. Nowadays, their treatment in the context of infection is to try to verify that they are infected with PET scanning, for example. And even if you cannot verify it, yet you suspect it, and you're having difficulty clearing the blood cultures, for example, and the patient seems to be failing, removal of the entire system with a generator in the leads is recommended as a class 1 indication. We also remove these devices in patients who have gram-positive endocarditis, not affecting the device itself or not proven to affect the device itself, but that which resides on the leaflets. So what are our current outcomes? Well, certainly these are not pretty, especially in the current era of the opioid epidemic. Our 6-month mortality rates across the board in patients with endocarditis, young, old, and everyone in between, is about 1 in 4 patients at 6 months. Hospital mortality rates, even under the best circumstances and in the best center, close to 12%. 6-month mortality rates, 1 in 4. Nowadays, nearly 2/3 of patients who present with acute endocarditis undergo surgery during the acute phase of the illness and before completion of a 6-week course of antibiotics. Nearly 2/3. When I was in training, I would say that probably 5% of people, or patients, I should say, with endocarditis underwent surgery acutely. Now, nearly 2/3. Perioperative mortality rates are not low, in the 5 to 10% range, but there's actually a very, very low rate of reinfection of a newly implanted prosthesis. A word or two about prophylaxis. This is an interesting population study from the UK with some of my collaborators that I've been working on with respect to the notion as to whether or not antibiotics given prior to dental procedures actually prevents endocarditis. But this is a population study that looks at the incidence of endocarditis as reported to the National Health Service before on the left-hand side of this screen, and then after on the right-hand side of the screen, the decision by the National Institute for Clinical Excellence in the UK to prohibit the use of prophylactic antibiotics in about early 2008. And as you can see here from this epidemiologic study, there was an uptake in the incidence of endocarditis per 10 million persons in the UK, about 35 more cases per month than would otherwise have been anticipated on the basis of the rolling averages prior to the proclamation by NICE not to provide antibiotics. There have been similar studies in the United States since the AHA recommendations around this time to specify the use of antibiotics only to those persons at highest risks for the development of complications of endocarditis, not highest risk of ascertainment of infection or development of infection, but actually highest risk of a complication, namely those with a prosthetic heart valve and those with a prior history of endocarditis. So I wanted to summarize as well by reaching back out to our infectious disease colleagues and recognizing the work that they've done here. There have been studies on the use of intravenous and oral antibiotics in order to reduce the length of stay in patients who are admitted with endocarditis. I think you're probably all familiar with the POET trial that was published 2 years ago that did show that in stable patients, after 10 days of intravenous antibiotics, it seems that you can treat them with another 3 to 5 weeks of oral antibiotics and achieve comparable outcomes compared against using intravenous antibiotics throughout. Very carefully selected patients, all patients undergoing repeat transesophageal echocardiography before a decision is made as to the safety of switching to oral antibiotics at about day 10. So I'll summarize by saying that there are variable modes of presentation. I like the historical aspects of this disease. I like the interface between medicine, cardiology, surgery, neurology, nephrology, and all things in between. There's an increasing role for advanced imaging with people like Dr. Hundley and others who've really shown us the way about what it is that we might not have appreciated previously. This is a wonderful example of a multidisciplinary team approach to the treatment of a very complicated disease in a very complicated population. We constituted an effective endocarditis team here about 3 years ago. It's very, very busy and one I think that is increasingly utilized across a broad range of caregivers, given the nuances that we often encounter. There's the increasing performance of surgery in the early phase, and I think that's a good thing. We need to reduce the variability in care that exists within our institutions and across our institutions. I do think that we can do better with regard to getting more people all the way through this at earlier stages and with less cost. And there have been tremendous lessons learned about endocarditis and about the confluence of the pandemic with which we are still dealing and what this means for vulnerable populations across all types of races and ethnicities. I do think that the recent past has been a learning opportunity and a sobering of our self-assessment with respect to how well we're doing for the people who live in our own communities. I want to thank all of you at Virginia Commonwealth for the opportunity to meet with you at Medical Grand Rounds, and I do hope we have time for some questions. Thanks again.
Well, thank you, Pat. Thomas, you're on mute.
Yeah. Thank you, Dr. O'Gara. And for everybody in the audience, if you could use the chat box or the Q&A function to ask any questions, that would be great.
Pat, I've got a quick question. This is Greg Hunley for the other listeners. Are we looking at immunotherapy in any way to treat endocarditis? I mean, we're seeing a marked use of that in treatment of cancer. And, you know, I know we've talked a lot here about traditional antimicrobial therapy, but have there been any ongoing studies to look at the role of any new immunotherapy strategies?
Not that I'm aware of, Greg. Obviously, a slippery slope in actively infected individuals with respect to interventions that would possibly attenuate the inflammatory response, recognizing that you might need as many host defenses as possible to get through the early phase. But I'm not aware of things, certainly not in the same ballpark with CAR T therapy, for example, or checkpoint inhibitors or other things. Good
and
question.
One real quick question, for those with implanted devices, really doesn't matter on the microbe. When you have valvular endocarditis, those devices, regardless of the microbe, they pretty much have to come out.
Yeah, I think so. You know, there's something about the long length of these intracardiac leads. It provides this wonderful milieu for organisms to hide from antibiotics. And as you know, the longer the lead is indwelling, the more likely it is that a biofilm forms on it, and also that there's webbing and endovascular incorporation of the device leads into the wall of the vein, for example, or the right atrium, or across the tricuspid valve. It's a perfect spot if you were a Staph aureus bacterium and you wanted to choose where it is to hide out, multiply, and cause trouble. It would be probably along the length of an RV lead. Yeah, I see some questions here about whether safe injection sites have affected the rates of endocarditis in states and localities that have implemented them. And I am not aware of a study that has looked at this, number one. I can only share the Massachusetts experience, and it's been an uphill battle, of course, to establish safe injection sites. But certainly in our state, we've only seen a continued increase in the use of both injection drugs as well as in the incidence of endocarditis. So I think it would take a more forceful public policy intervention. There's another question from Dr. Mayer about whether patients were stratified by Apache score as to whether or not to offer surgery or antibiotics. I think in the vast majority of studies that have been performed, Dr. Mayer, there's a huge over-reliance on observational data that can never, ever account for the confounding, the bias, and the selection that goes into decision-making around surgery versus no surgery. And I think you're pointing out one of the huge deficiencies in doing or trying to gain insight in an area like this, where the diagnosis is not a frequent one, say compared against heart failure in hospitalized patients, and that individual approaches to treatment can vary. And it's very, very difficult to randomize patients in studies with endocarditis. We're trying to get one off the ground in the NHLBI Cardiothoracic Surgery Network, in which I participate. It's taken us now 18 months to try to get a protocol together that everybody would agree to. It's a very simple question about operating early versus operating later in patients who have endocarditis, who need surgery, but who have had a stroke. So I do think the surgical population is inherently more difficult to randomize to trials than a non-surgical population, but it's important that you've pointed out this deficiency. And then Dr. Srinivas has stated that he understands that we want to get patients to stop injection drug use, but harm reduction is a key step on the path there. And of course, I couldn't agree more. There are many, many facets to injection drug use that I have not touched on and about which I'm very respectful. And I would amplify the call for the kind of multidisciplinary team and policy approach we need to tackle this problem. I don't think it's going to get better in the near term. Certainly there's some hope that the economy will perk up, we get more people back to work. That remains to be seen, whether it translates into a reduction of the kinds of struggles that people have that may lead them to the use of injection drugs. Certainly the social determinants of health and all of what you're pointing out are very important in that equation. And then there's a comment here from Dr. Sternberg about whether I could address the risk of endocarditis in patients who've undergone transcatheter edge-to-edge repair with a mitral clip. The answer is there have been a handful of cases reported with mitral clip infection, but not certainly to the extent that have been reported with regard to patients who've undergone transcatheter aortic valve replacement. The mitral clip device is relatively smaller. It's more of a moving target because it's attached to the mitral apparatus and going up and down. It doesn't have an annular attachment, for example, and it's way out there on the valve leaflet, which is in most regards an avascular structure. Certainly there have been case reports, but they are few and far between. I think what we worry about, of course, are the next generation of transcatheter mitral valve replacement devices and the use of any kind of transcatheter device in older patients who are sicker, who have a broader portfolio of comorbidities, and who would be more susceptible to infection. Great.
And I am not seeing any further questions at this time. I do want to thank you again, Dr. O'Gara, for your time and for your presentation today. And if there are any other questions from the audience, I think maybe one more minute. And if not, then we can go ahead and end the session.
Terrific. Happy to do whatever you'd like. I do want to thank Dr. Syme and also Dr. Hundley for this opportunity. I know there's never a good time for medical grand rounds, is there? Whether it's Monday morning, Friday afternoon, Thursday afternoon. And it seems to me about every 3 years we flip a coin and we go to another day of the week. And then you still get these notes that says, why aren't you at grand rounds?
Importantly, we can't even provide lunch at the moment because of
no. Yeah, we've lost the lunch and sort of the personal interaction. But I always like to say how lucky we are, to have these opportunities to meet with each other. And it's such an exciting time to be involved in medicine. And I really wish the residents all the best. And I want to thank you for the work that you've done on the front lines in the hospitals in the COVID pandemic. We can't really function without you. Stay with us, and I think you have a very bright future ahead of you. Thank you.
Thanks, Pat.
Okay,
Thank you so much.
you're welcome. Bye-bye.